spinal injury. All right, so we will start with the spinal injury and go into autonomic dysreflexia. All right, so the first thing is that it's not brain, so it's spine, and then spine is either going to be acute or chronic. All right, so that's based on time and location, ER or wherever you are. So you always want to be asking yourself that, because that's going to put you in the right spectrum of what I need to do. Recognizing that spinal shock, they're going to go through these 4 phases. Spinal shock looks specifically like this. It looks like they're paralyzed. However, temporary, if it's not an injury, and we talked about that, there's a complete injury and an incomplete injury. A complete injury is when you sever the spinal cord. And we said that 1 through 4 is acute, and that person becomes a quad. Well, that means that there's an actual injury. It doesn't mean it's a temporary injury, like just a shock state. It means that you've actually severed that spine. They're not going to walk again. That's where they're at. NCLEX will not test on the temporary part. They will test just on what it looks like, and then this progression to this. So within 30 minutes, up to, I forget to look at the times, you'll have a patient that you're looking for neurogenic shock. And the differentiation is because they lose vasal tone, so they become boggy on the outside, and blood pressure goes down. They become bradycardic and poikilothermic, irregular temperatures. So we do this. We airway support, we do vasopressors, and we give atropine for bradycardia. So this patient will definitely be on a monitor in spinal shock. So think of a neuro ICU. That person is there. Now, once they're in it, though, it's predictable. So it's not like you're rushing along with sepsis. Now, sepsis goes into progressive phases, right? So, and we'll talk about that when we talk about next week, when we start to cover trauma and shock. You start moving with sepsis in the initial stages, then they're hot. But once they go cool, that's it. That's the progressive, that's the point of no return. That's a bad sign. And that's really, really acute. However, neuro goes back to the light switch. I mean, this is a hemodynamic phenomenon, but it's not really going to be, they would die of a complication of something that you're not doing over here. And that's kind of what you're looking at when you're looking at this condition. It's not so much that the patient is decompensating right now. It's just we're treating what's the underlying. Stay awake here. All right. Airway, right? Heart rate, atropine, NG tube, right? Postrenal, GI, everything's going to be shunted. So it's natural. The body's in chaos right now. So natural mechanism is to shunt. So therefore, everything, the rest and digest starts to go to sleep, the butt and the gut. So we start to just be preventative in what's going on, right? So the other thing that we're going to look at is, yeah, all these sheets are on Mesa. I mean, I posted on Mesa and on Nursing Camp under the class page, right? So also I've been posting them on neuroscience and stuff like that. So you can't find them. All right, so the halo management. Now, it doesn't necessarily mean you see halo and you think, okay, well, this is an acute thing. No, it's kind of a chronic thing. I mean, it's just something you have to be aware of and why they're doing it. So, and it goes back to this phase over here, because that thoracic injury is not going to be a quad or anything like that. So they're still good, but they still need stabilization of that spine while it heals itself. Or, because if there's no, so think about this. If this person has a halo and they're in that temporary stage, if they're in that temporary stage, we're just waiting for it to come back to the normal level of function. So they get the halo, they get where they're at, all right? But if it is an actual spinal cord injury and they're paraplegic, they're not a quadriplegic or anything like that, they just have lower, we're still going to stabilize that spine, right? So pin care, all the basics of infection comes into it, meningitis, and so on. Medications, just being familiar with them, not so much nuts to know about them. Steroids, atropine, plasma extenders, antispasmodics, H2 blockers, stool softeners, etc. All right, so now we're going to get into chronic spinal cord injury, which we talked about this morning. I'm an eraser. Why? Nice. And nice. All right, so C1 through 4, breathe no more. That's the acute process. C5, this is all cervical, so cervical is acute, always. Thoracic is pulmonary. And then splitting hairs about the different types of cord, incomplete versus complete versus bouncy quad. Right? So I don't think that NCLEX is going to test on these type of things because this is not most likely, right? That somebody gets an anterior versus a posterior cord syndrome. Bouncy quad tends to be most common because of gunshots, right? And it's very characteristic ipsilateral. Quadriplegic, paraplegic, right? So all different areas there. I say complications, you know, a lot of this stuff is kind of chronic. So it's kind of covered a little bit with stroke and different things like that. But a lot of this kind of transcribes into the other areas where they focus more on this area, the flaccid versus the urinary, because this is a potential problem when we get into autonomic dysreflexia, all right, which we're going to get into now. So let's talk about that. All right, so autonomic dysreflexia. All right, it's a condition, right? You need to know it. It's most likely to, because you're going to most likely take care of a quad, or you take care of a paraplegic. You'll have them on the floor. And as we know, any kind of quadriplegic or paraplegic is a risk for autonomic dysreflexia if it's T6 and above injury. So a T6 and above injury is autonomic dysreflexia. Now it gets a little confusing because of, you know, they'll say a C5 injury. They won't say T6. You know, you have to just know if it's above T6, autonomic dysreflexia. Always the same thing. So let's talk about the basics of what it is. And we talked about this earlier today. So let's take the spinal cord first. All right, so you have T6, which is the level. And above T6, T6 to 12, we talked about the bladder earlier, right? We said that above would be supraspastic, would be a spastic bladder, okay? That's important to know. And the reason it's important to know is if you think about that, this patient bladder is filling up and the urine keeps on going and filling up this bladder. Well, just think about that when you have to go to the bathroom, right? So you have this stimulus going on, this feeling of having to go to the bathroom, right? Well, if you're paralyzed, you don't feel it, but your bladder does. Get it? So you don't have the pain, the feeling of what it really is. All you have is the bladder filling. Okay, that's why it's such a big deal, because it could elicit this stress response. And this whole autonomic dysreflexia can start and it can be problematic for the patient. Okay, and that's why it's such a big deal, is because of a normal person will feel a micturition reflex. You're going to feel like you have to go to the bathroom, but a paralyzed person will not. And that's where the problem comes in, because it's happening, but they don't know it's happening. All right, so basically what happens is it goes back to this. And I usually take a thumbtack, right? So you have a thumbtack and you're sitting on it. What the hell is that? Is that a boat? All right. It's the worst thumbtack ever. I've drawn better. I know that. Jeez, that was ridiculous. So you have the person, hello, on the thumbtack. Okay. And that's pain. Okay. So we're talking about this right here. Okay. So think about this. You have a pain response. You have a level of injury T6. So that pain response is a stress response. So think about running from the bear, okay? And you're running away from this bear, and so you're going to shunt, right? So it goes to the heart and then to the lungs, right? And the rest and the digest, the butt and the gut, go to sleep. On a vascular level, you go from normal tensive to vasoconstriction, right? Because that's how you get the blood to the core, right? So you could run away. So that's kind of what's going on once you get pain, okay? And that's the key here. You need something to be the stimulus, and that's these triggers, okay? So the first question is, we try to prevent these triggers. And that's kind of the principle behind this. So this is basically the recipe. If the patient has a UTI, has a T6 and above injury, their risk is autonomic dysreflexia, okay? So that's why it's a very tricky type of thing, because it's acute. And, you know, if they have a UTI and you're not monitoring it, it could elicit autonomic dysreflexia. So catheter could be kinked. Same principle, right? So you have this catheter in them, indwelling or something like that, and it is kinked. Well, the kidneys are still working, and they're trying to get out, but it's kinked. So it starts to back up, autonomic dysreflexia. So another stimuli. Now, they can't feel it, so they feel it down here. So below becomes pale, like a goose. And that's from over here, where you see on the cold, pale goosebumps. That's on the right side of this over here. So below it looks cold and pale and goosebumps, right? Because thermoregulation and those type of things, vasoconstriction is not priority. So you have you have poikilothermia, right? So you have goosebumps, you have cold down there. So the vasoconstricted. Now the other thing is, if that's kinked, that would happen. So you would unkink it. Right? That's the principle. Kidney stones, same principle. Constipation, that makes sense as well, because constipation, once again, you're not moving your bowels, so therefore, if you're impacted, then you're going to have a stimulus that you don't know what's going on. So hence, you know, rectal dilatation, those type of things on Sunnyview. So you're going to have a sense of preventative actions to deal with a potential problem. So that's why at Sunnyview, they go around and they do digital disinfections, different things like that, stimulation, right? So that get the bowels working, because constipation could cause autonomic dysreflexia for a T6 and above. Hemorrhoids, real painful, depending on how bad, right? So once again, pain response doesn't go through. And then pressure ulcers. Now they're sitting on a pressure ulcer. They don't know it. They don't know what's going on. So the same response. So that's an easy piece of this. It's because we prevent this from happening, right? And you see belt on too tight. Well, that's a pretty interesting thing. And that's why we see quads with elastic bands. We don't see belts on them. Just think about that. Thanksgiving, you get a belt on, you're like, oh, loosen it up, relax a little bit, right? So, well, I mean, if you're a quad, that belt can cause pressure. Next thing you know, stimulus, pain, and autonomic dysreflexia. So we do some mechanisms already right away to prevent it from happening. And so that's assessment of bladder. We do intermittent catheterizations. We check rectally for moving the bowels. We treat the underlying causes. We check for infections and different things like that, because we don't want it to happen. And that's the goal, right? Because autonomic dysreflexia is an emergency. It's acute. I mean, you're going to do something now. A doctor needs to be called. So let's talk about it. So let's talk about the what does the patient look like? Well, we already know that there's some specific things underlying that could cause it, and that's called the stimulus, right? This is just me explaining how it works, but you know, this is more important. This is all preventative. This is all teaching. This is all higher Maslow, and this is all about patient presents with a T6 injury and has this, a catheter, right? Autonomic dysreflexia, check the catheter. Basic principles, assessment, right? Because we don't want them to go to autonomic dysreflexia. So how do I know what's going on? And if you've been doing questions, you've probably seen the autonomic dysreflexia questions. It's very testable because there's a lot of paraplegics and quads, and it goes back to the nurse coming out of school. Now, the basic principle is that a nurse coming out of school shouldn't go into high acuity areas, right? Because it's just, can you function? Yes, you can function, but we've talked about that before. It's not a matter of being able to function and get by. It's more of a matter of being most effective, right? So majority of the population should go med-surg to basically get through that first year. Well, that's most likely that you would see a quadriplegic, paraplegic, all those type of things. And so therefore it becomes very testable. So let's talk about what it looks like. And that's very specific to autonomic dysreflexia. So we already talked about the stimulus. Person's on attack, and you have that mechanism of injury, and that's T6. So that T6 injury is indicative. So it could be T4, it could be T3, it could be all these different things. That's what you have to come into the realization when you see these questions. That's why you say spine, okay, chronic or acute, okay, where's the level of injury, okay, autonomic dysreflexia, all right? And so when you're looking at the patient, we're going to go over to this side right here. So what happens is that we already said that the bottom part, they're running from a bear, so they vasoconstrict. And so you see these vasoconstriction, cold, pale goosebumps, right? And that's just dysregulation. That's what's going on there. So what does it look like above? Well, as this message goes up, it gets blocked here. It can't go by. So system-wise, down on the legs, you know, they look pale. They're goosebumps. They're cold. And then there's a level of injury. So, but what happens is that the level of injury, the brain recognizes on the baroreceptors, on the neurological, not the neuros, the vascular. And you're talking, when we're talking about this, we're talking, you know, PNS, SNS, no, CNS, that's what we're talking about, right? So the brain is recognizing through the spinal cord that there's something going on in the body. It's running from a bear. And it's like, holy crap, they're running from a bear. And the patient starts to become, because they go vasoconstriction, they start to become hypertensive, right? Extremely hypertensive. And what happens is the body says, tries to go up there saying, hey, brain, we have a problem. The person's sitting on a tech, move this person. And the brain doesn't really get that message, but it does get it by second fiddle, right, from the neural system. And so it's recognized what's going on. And then what happens is it says, okay, well, you're cold, start sweating, right? Cool down, right? And then you start to get stuffy nose, headaches, flushing. So the flushing is just because of, this is all vasoconstricted down here. Then they start to vasodilate. And we see that with nitro, when you give nitro. Because nitro causes flushing in the body. So then what happens is the brain recognized that this blood pressure is like through the roof, really, really hypertensive, so it vasodilates. And that's why we start to see flushing. And extreme vasodilation. So you're going to see flushed, warm, and nasal stuffiness, blurred vision above the level of injury. And they'll be pale and cold underneath that. Now, what is that about? Well, your level of questioning will always be the same, right? So nurse walks into the room, sees XYZ. So you either presented with this, with the symptomology, pale goose, you know, that type of thing, flushed above, this anything, or complaining of nasal stuffiness, or complaining of, you know, blurry vision. So if you have a C6 injury, you have nasal stuffiness, you have autonomic dysreflexia. It's an emergency. Do something now. What you're really not seeing is that they're sitting on attack. That's what you see. So what could also cause it? Any pain response. You know, somebody left a pen behind, right? And the person had that under their butt. Now, you or I mean, we'll recognize it. You even think about that when you're sleeping, right? I mean, when you're sleeping and your arm falls asleep, right? Eventually, like Kevin, you know, I mean, you'll start to, you know, you'll wake up. And when you wake up, you know, your arm is asleep, so you're picking up your arm and it's like this, right? Because the fact is that pain response wakes you up, okay? And that's how the neurological system happens. This patient doesn't have it, okay? It's happening below the chaos, but it can't get past here. And then the brain can't get passed down. So that's why you have this differentiation between the two, okay? And that's why the patient looks like this above and then looks like this below. All right, emergency. So what do? High follows right away. Okay. Oh, but Kevin, it's a neuro patient. This is spine. This is chronic spine. Okay, this is not acute spine. This is not ICP. So that's why it's very different. It's the only time you see high follows in neuro. Okay, because all the other times you see low follows, you see spine. Only in autonomic dysreflexia you see high follows. And the reason is because of this condition that's going on. It's the best ditch effort of what you can do at this moment for this patient. And you're going to continually check that blood pressure every 5 minutes. Well, first thing you do is you put them high follows, you check, do they have a belt on? You know, what's the position they're in right now? You know, those type of things. What's the underlying causes? You know, you might check bladder, those type of things. Because if I can correct these things, I can potentially stop autonomic dysreflexia, but it's very difficult to do. So that's why it becomes a medical emergency, because that's why you have to call the doctor if the patient goes into autonomic dysreflexia. So what do we do as a nurse for a patient with a spinal cord injury, a chronic spinal cord? So we put them on, you know, stool softeners, right? So Colace, soupy poopy, right? We a lot of times we're like, okay, well, everybody's on Colace. Well, autonomic dysreflexia, those type of things with bowel problems. That's why we'll, you know, do you think that, you know, some of you, you know, they just randomly just want to check everybody's rectal and start to massage in there? No, I mean, the fact is you do it so that prevent autonomic dysreflexia. Okay, so it's necessary. It's necessary to do. Same thing with catheters, right? You're doing it to prevent autonomic dysreflexia. So when we're looking at this condition, it's always about prevention, right? But sometimes you can't prevent it, right? So UTI, those type of things, kidney stones, a catheter gets kinked, right? Because that could happen, right? Because you have a spinal cord injury, chronic patient, and a tech is in there doing care. These are chronic, right? So what, you know, I mean, what are you going to die from the pressure ulcer today? No, it takes time. So they'll be, you know, and they could kink that catheter because they don't assess, they don't think about those things. So they could turn in position, and then next thing you know, this patient's starting to cook, and their bladder starts to fill up, and they can't react because they don't have the capacity. So the message goes up, they start to go here, and then it goes back down there. So autonomic dysreflexia, I mean, it's a very interesting acute situation, because the thing is that, so what can we do for medication-wise? Well, I mean, we check the blood pressures, right, because stroking out, all these type of things, because severely hypertensive. And then, who works at Sunnyview here? Akima, you work at Sunnyview? Or Nikita? I think it's Nikita. Nikita in here? She should be. Find her. Oh, there she is. Nikita, you work there, right? Would you unmute yourself? She's like, I'm just watching television. I'm not really paying attention. All right. Well, anyways. Like, Sunnyview is a place that you'd see this, right? So that's kind of the priority. And she's not even paying attention. She'll fall asleep over there. All right. I get it. I'm trying to. All right. Where are we at? All right. So let's run through it really quick. So autonomic dysreflexia, pain. Pain response, T6. T6 and above, going to get it. Okay. So pain goes up, vasoconstriction, pale goose, pale, goosebumps, emergency, high followers right away. Assess what's going on underlying, recognize that on the top, it's going to be this. What about medications, right? So nitrates, right? That makes sense, right? Nitrates vasodilate. If you have extreme vasoconstriction down here, this patient, you're going to try to vasodilate them. So not only nitrates, but like nitroprusside would be a good example of that, right? So, which is going to cause vasodilation, right? We use nitroprusside with CHF patients. Remember when I said there's so much fluid on board, we give them this IV medication so that they can relax that outside. Okay, let me see here. Okay. Care clean those floors. So give that practice assessment. Okay. Is the hypertension in the lower body? Yeah, the hypertension is in the lower body, but I mean, you're doing a blood pressure cuff, right? So, I mean, you're going to feel the blood pressure. Blood pressure is what it is. Once they find the underlying cause correctly, how long? Yeah, that's all over the place as far as the exact time. More important is just that you prevent it. You know, I mean, that NCLEX approach it on the holy crap. I walk into the room, the patient's complaining of stuffy nose. This is a bigger issue than what it is, because they give you the data, cervical injury, quadriplegic, those type of things. So there's usually enough data in it. Like, so for example, if they ever gave you like a quadriplegic, right? They didn't give you a cervical injury, but you would need to know that a quadriplegic is a cervical injury. Got it? So, and is at risk for autonomic dysreflexia without saying cervical injuries. Okay. So if a patient has like leg braces, they don't have autonomic dysreflexia. Spinal cord injury with leg braces on, they are not going, they're going to have a lumbar lower. Okay. And that's just over the top, like splitting hairs. So even though the body is dilated, giving nitrate won't make them bottom up. No, that's the least of our concerns as far as bottoming out. We're just going to treat and hopefully, you know, I mean, we call the doctor, outside oscilloscope, nothing we're going to do. If we're studying the content, we just have to know that, you know, I mean, hydralazine, which we see is the only IV kind of ACE inhibitor, you know, we give it for hypertensive crisis. We're going to monitor the blood, bowel sounds, bladder, and triggers. So you always assess, are these things going on that's causing it? And then you correct it. And then you go to the next thing. Now, the big thing about these questions, it's kind of like a chest tube question, okay? It's not it's always going to be the same things that you're tested on about the content, right? It's always about assessment over here, right? Prevention, teaching, what you do when you see it, and what the patient looks like, okay? It's always that, not so much of this. This is nuts to know. I mean, we test on it, we look at it and stuff like that. If you're doing questions, you know, you're exploring the content. But more important is that the doctor is notified of what's going on here. And hopefully it resolves itself. But you're talking about a stress response. When a person goes down for surgery, they shunt, right? You learn this in nursing too. Because they're in surgery, they're being cut open, the rest in the digest goes to sleep. Hence, do you have flatus? Are you moving your bowels? You know, when's your urine out? You know, are you going to the bathroom yet? Right? Because we're waiting for the shunt to come back. And that's why you call the doctor when that doesn't happen, because somewhere along the lines, there's something going on with this patient, that they're not going back to normal, and they should be. So they have paralytic ileus, and then that's a further problem. And that's nursing too, right? So, I mean, it's important to recognize that autonomic dysreflexia, when it's mixed in with a bunch of different questions, it tends to confuse you about, like, you know, 1 minute you're doing this, 1 minute you're doing that. That's why if you just start from the very beginning, Neuro hat, you know, brain or spine, and just move on down that cycle, and then you can get to what you're going to get to. Because if they're going to test on neuro autonomic dysreflexia, I mean, it's just this way. Not so much what's nuts to know here. So it's not that complex. It is physiological, though, if you think about the shunting, the vasoconstriction. That's why they have the goose. That's why they're flush, the dilation. The brain is just trying to deal with what's going on. Now, somebody asked about, like, the hypertension. Now, when you have autonomic dysreflexia, you don't know whether this person is quad or not, right? So, I mean, that part of it's kind of irrelevant. It's just that you're seeing the symptomology going on, right? So you're seeing that. And if you're doing enough questions, you've seen the questions as far as, you know, the patient being flushed and pale below the level of injury. That's always emergent. High follows, call the doctor, anticipate antihypertensives, anticipate nitrates, you know, those type of things. And that's kind of why we do it at the end, because it is just a piece of content that needs to be just at its own level, you know, literally T6 and above. So any other questions about this? So even on, okay, so if the underlying cause is corrected, we don't medicate. Assess the patient, always back to the patient, right? So, I mean, you do the intervention, then you see, okay, so like we saw in that TERP question, right? I can't urinate, this and the other thing. So you assess the bag, check for kinks, you correct it. How do you feel now? Same thing, go right. It's always, I do the intervention, I go back to the patient. You walk into the room, shortness of breath, you know, distress, you high followers, right? Do your assessment, right? How do you feel, this and the other thing. So it's always intervention, then assessment. Right, so the intervention would be unkinking. You know, you assess that there was kinked, you unkinked. What's the patient look like now? Right? And if they're still the same, that's not the other thing. High follows. Well, they'd be in the high follows anyways. And call the doctor. So high follows before calling the MD, always, right? So that's the immediate thing, you put them up. You put them up, and then, because that's an emergent thing, it's outside your scope, you know, as far as, because if it's already starting to happen, you know, I mean, you got to get them up and what's going on. Because you have to think about it in the sense that, you know, it's an acute situation, you know. And in the neuro, I mean, everything else is always low followers and some, you know, and stuff like that, supine. And this is the only time you see it, you know. So I've never seen it. So, you know what I mean? You know, it's just, why high follows? What does it do? It has to do with the vasodilation, and, you know, it's the best ditch effort for that patient. Otherwise, if you put them supine, they'll pool, right? And they could stroke, for that matter, right? Because the hypertension is so high. So more important is to, right? So if you put that patient back, hypertension, up, right? I mean, think about that in the brain sense, not in the spine sense, right? Spine is, but we're talking hypertension, and that's what the issue is, right? Because it's harder for pressures to go up, right? Any other questions? All right. How do people feel so far? Atropine, why? Body's they're going to have rebound, hypotension, tachycardia, bradycardia. The body doesn't know what to do in this situation, right? It's in chaos. So you have different pathways, sympathetic, parasympathetic, right? So think back at, when you're given atropine with the eyes and drying and dilation. It's the same concept as because of the innervations of the nerves. And, these baroreceptors are everywhere, right? So the chaos is patient starts to go up, most patients do wish, vagal down because hypertension, right? So in the case of this, now if the brain recognizes that this patient's really hypertensive, right? Is it going to increase the heart rate or decrease the heart rate? It's going to decrease because it's not going to increase it because it's hypertension, right? So it's the direct opposite. So it's trying to deal with what's going on, and trying to solve the problem. However, it can't get past. So it's only on the top part it's dealing with it. And that's the problem, is that the brain is trying to deal with it, but it doesn't know. The brain is just a, response system. It can't pass that spinal injury. It can't go past here. And that's why you see a characteristic. But the peripheral nervous system is still has receptors. I mean, you think of the dermatomes going out, right? So they're still going to pick up some sort of, think about that, C6 injury, right? They have some bicep movement, different things like that, So you think about these cranial nerves as you start to move down, they're pretty, like I told you before, remember when we went to the doctor and I said this, right? I said both my fingers bilateral, and the reason was because of cervical, right? But it was bilateral, so it was acute. Same sort of principle. This is where you have all these receptor sites and the brain just picks it up and runs with it. Because this hypertension gets really, really high. Anything else? Nope. Any other questions? Was it easier doing questions before or after? Yeah, probably better before. We'll see for have trouble speaking to. Yes. Yeah. More about breath hunger, those type of things, articulation, it's more respiratory. And then even at C5, you're still going to get a trach, those type of things. They won't be able to oxygenate. They can't expand their lungs, Yeah, I mean, this is some, there's a lot of content, right? So, I mean, but that's it. That's all the content, right? So that's it. We're at that plateau of everything. Yeah, Neuro's kind of one of those least favorite too. Yeah. I mean, it's what it is, go from there. So more questions. I think it's hard to do the, you think 10 questions is better? I'm thinking that 20 seems a little long because we talk about it. Yeah, Kara. Yeah, break it up, right? Maybe you do 10 and then break it up. Yeah. We need to start doing more questions. So, that's kind of what happens towards the end of the semester. Doing questions. So, because especially as we get closer, so that's the neuro exam, right? So 50 questions. We'll do a quick run through tomorrow. We'll do some questions tomorrow, for clinical, and then we move to trauma, ER, trauma, ICU, and blood. So shock, blood, trauma. Right? It's good content. You know, I mean, we're back to normal. I say usually it's back to pathophysiology. It's back to this part, so it's a little bit more manageable as far as like, you know, just getting back into the med surg piece of it. So neuro tends to be its own little thing. Okay, I got to memorize all this stuff and understand, and then you have to forget about it until you see it in questions and stuff like that. That's why it's the neuro app. But we will do, we'll break up trauma, ER codes and stuff like that, and then go from there. Anything else? No, nobody's got nothing to say. Spastic bladder with antispasmodics treat the spasms. Yeah, yeah. So your choline, baclofen, and such like that. Now those tend to be chronic meds, so I don't cover a lot of them, you know, because of their antispasmodics, and that tends to be chronic long-term treatments. I cover a little bit more of this, the acute process of it, because I know you've seen those before, and they've talked about them with chronic patients and stuff. So yeah, it's a good question. They have, you know, I mean, if you have a spastic bladder, if you think about it, it's always spasm. So they'll have antispasmodics on board, and just to keep things comfortable, you know, for that patient. And although I don't test a lot on like baclofen, because baclofen shows up on intrathecal baclofen with, I think, maternity and or not, and definitely in nursing too. So the meds on this is more Decadron, you know, new things that we saw. All right. Any other questions? All right, rock and roll. See you tomorrow.